manifestation. And 27 it was 6.6, and the DCT test done came as positive, but the peripheral smear there is no evidence of hemolysis, and LDH was also elevated. Here there is drastic fall in HB, DCT positivity, and LDH elevated, and the bilirubin still in the higher range. OTPT all thing improved. When DCT positive rapid fall in HB, we thought of any autoimmune hemolysis.
What is the one thing that should have done? Did you do a haptoglobin?
Haptoglobin, sir. We didn't do that. We actually.
That is very important. If it is negative, it confirms that there is hemolysis.
Yes.
What is the reticulocyte count? Reticulocyte count?
Sir, reticulocyte count is 2%, sir.
RPI, reticular production index. Did you
sir, actually, not sir.
Okay.
So, sir.
Okay, go on.
Sir, then we thought of first we have to rule out other causes, but first we have to look for our prescription also, whether after admission only he had this drastic fall in HB. So we reviewed our prescription. It was modified ADT, injection piptas, and N-acetylcysteine and syrup Portflor was there. Then we found the literature, and we found that with the piptas can cause hemolysis. Some literature also found ceftriaxone and piptas can cause hemolysis.
Does it produce immune hemolysis or non-immune?
Sir,
immune or non-immune?
No, immune mediated, sir. Immune mediated hemolysis.
Okay.
Mediated. Then piptas was stopped and 1 point washed RBC given. At the same time, his lower limb edema still persisting in both, in spite of giving human albumin. So we opted for a UST lower limb venous Doppler. It was came as evidence of deep vein thrombosis in the left lower limb in the saphenofemoral venous system. Here patient is now having hemolysis, thrombosis, and a recurrent pulmonary tuberculosis with a multiple cavitary lesion. So we thought of any underlying malignancy. So first we sent some tumor markers, not that much significantly elevated. Then we sent some, when CEC thorax and abdomen was done, it showed volume loss of the right lung, and most of the right lung is replaced by areas of consolidation, fibrosis, traction bronchiectasis, and multiple irregular cavitations with the air fluid level. And also there are multicentrial lobular nodules with the few of them having tree-in-bud pattern in the bilateral parenchyma, patched area of fibrosis with the traction bronchiectasis. Probably the result came as TB sequelae with the reactivation. And in abdomen and thorax CCT, the thrombosis involving the left common iliac vein, femoral vein, left external iliac vein, saphenofemoral vein, left innominate vein, subclavian vein, and internal jugular vein. But there is no evidence of arterial thrombosis. So there is extensive thrombosis in the left side of the body, in the thorax, abdomen, and the lower limb. This is the CCT film showing fibrosed lung with multiple consolidations, cavities.
Did you start him on heparin?
Yes, sir. We started on heparin. Heparin infusion was given for the first 3 days. Then changed to 6th-hourly regime. This is the DVT in the left femoral vein and left external iliac vein thrombosis. We also done echocardiography to rule out any cardiac, if there is any cardiac thrombus or like that, but it was normal. COVID-19 antibody also we sent whether there is any COVID co-infection at 1.5 months, and COVID can cause this much extensive thrombosis, but it came as negative. We again repeated ECT on the second day, also it came as positive. We have to look for any vasculitis also because he had cavitary lesions, then this much thrombosis, hemolysis, but ANCA result came as negative. D-dimer was came as negative. Any fluorescence were negative. Then we have to thought of any viral infection. EBV, CMV, and PCR, all things were negative. EBV, IgG were mild positive. Then this is a graph just I depicted because this is the level of hemoglobin in the patient. after admission, and then after PIPTAS is stopped, it improved. And on the 4th, it is came as hemoglobin is 10.5. So we found the culprit for hemolysis is PIPTAS only. Then we have to evaluate for the thrombus. What's the cause for thrombosis? There is no evidence of any malignancy from the CCT reports, and also from the tumor markers, we didn't get anything.
Antiphospholipid syndrome?
Sir, APLA was negative. APLA work were done. It was negative.
Probably it's a provoked thrombus. It's not due to anything. It's due to a provoked thrombus due to all this comorbidities and stay in the bed. That is the most likely cause. Did you find anything else?
Sir, thrombophilia workup were negative.
No,
but
we should not do it.
But
We should not do it. No, this is all normal. I think all this are normal. Yes.
So we found some article where there is any pulmonary tuberculosis can be this much. We found it is a emerging risk factor for venous thromboembolism. So many cases of deep vein thrombosis and systemic embolisms are reported. So we already started on anticoagulation initially. Heparin infusion was given, then later changed to rivaroxaban. Then we re-challenged with the INH and LFT was monitored. LFT final diagnosis 18-induced hepatitis solved, recurrent pulmonary tuberculosis now on modified ATT. Then drug-induced hemolysis, probably because of beta-lactam group. Then disseminated venous thrombosis, we have to suspect where there is secondary to tuberculosis. This much extensive thrombosis.
It's possible. Okay. So what was the DCT was repeated to see whether the immune reaction has disappeared?
Sir, when came for review, his results were like this: hemoglobin 12.2 and DCT test negative. Total count was improving. All things were improving, sir. Only and his.
So there's a good possibility that it is due to a drug-induced, definitely a drug-induced immune reaction, and the thrombus is probably the disease itself, likely to be the disease itself. Anything to add, Sharma? Sajeev?
Parvati, you said it is a autoimmune DCT positive, is it not? Yes, hemolysis. Yes. Triggered by the drug, piperacin tazobactam, is it not? It is. Yes, sir. Can in autoimmune hemolytic anemia, DCT can it be negative in any instance?
Which one?
Instance? DCT negative.
Supply. Okay.
Can you think of it?
Yes, sir.
I tell you, see, it can be negative sometimes. Usually you do it for IgG antibody. If it is for IgM, it can be negative. Sometimes it is complement that is deposited that causes the havoc. So you have to do anti-complement, direct antiglobulin test with the anti-complement antibody. Third one is the RBCs will be deposited with the antibody. The number of molecules on the surface of the RBC to be positive, give a positive test will be around 200. If it is less than that, hemolytic anemia can occur, but DCT will be negative. Are you following it? Yes. And after a brisk hemolysis, whatever RBCs have been coated with the antibody, they have just got lysed. So the remaining RBC might not have been coated. So direct antiglobulin test can be negative. So there are situations, just read about it, situation where it can be autoimmune hemolytic anemia where a direct antiglobulin test can be negative. That also you have to think about it. Got it?
Sajeev, anything to add?
I will not add anything on the other aspects.
Okay, sir.
Discuss a bit on the regime that is given to the patient. Now, this particular patient is taking anti-TB drugs for the third time. So even before I start treating the patient, my concern at the start of treatment is whether the patient would respond to the anti-TB drugs and whether the patient would have another recurrence, fourth recurrence would occur. So there,
I would like to ask whether the newer lines of drugs should be started for this patient.
No, but in this case, my opinion was coming to that the current regime that we are giving is, I would feel is inadequate, because ofloxacin is no longer considered as an anti-TB drug in any international guideline. So if you look at any international guideline, nobody even mentions ofloxacin in the guideline. So if at all you want to give a quinolone, the would be a levofloxacin, high dose levofloxacin in India, because there is very high prevalence of fluoroquinolone resistance among TB patients in India. If you go to states like Maharashtra and UP, about 50% of the multi-drug resistant TB, 50-60% of the multi-drug resistant TB there are resistant to fluoroquinolone. So fluoroquinolones may not really work, and the reason of so much of resistance occurring is also because of the overuse and misuse of fluoroquinolone. So as a postgraduate student, what I would request Parvati to understand is that the key drugs for this patient, particularly for a recurrence not occurring again, in this case would be rifampicin. So even in a patient like this, with all the drug-induced hepatotoxicity, we still, I mean, Sharma sir was discussing at the beginning on whether it is actually drug-induced hepatotoxicity. With all these complications, you know, the patient has, the liver function has come back to normal, we need to consider that. But a high proportion of patients who had a drug-induced hepatotoxicity can always go back to a INH rifampicin, often INH or rifampicin, or maybe both of them. Maybe pyrazinamide may be a bit difficult in a patient like this, but often those drugs are possible. So you would have to consider the long-term, you know, prognosis of this patient with respect to tuberculosis and consider those drugs. The second aspect is that you have a first-line LPA available. So the program actually in a patient like this, you could actually reach out to the lab, intermediate reference lab in Trivandrum, and they would actually give you the second line LPA results also. And the second line LPA would tell you whether the streptomycin that you're giving to the patient and the ofloxacin that you're giving to the patient are actually working or not. I mean, if there is resistance to fluoroquinolone already, then your regime is, again, would be called to question. So that result also would be available. They would not routinely be doing a second line LPA because INH and rifampicin is sensitive. But as a special case for this patient, you can definitely ask for the second line LPA, because the isolate for the first line LPA would still be available in the lab, and they can easily do a second line LPA within 8 hours for you and give you the result. So that is also something that is possible. The rest of it, I think the seniors are discussing, and I will not comment further. Thank you, sir.
Sharma, anything to add? I think we'll close this session. It's a very interesting case. Thank you, Suma, for the case with lot of complications and some things we are not able to say for sure. For example, the DVT was very surprising, and it's an extensive DVT, so it should have a cause which we call it as idiopathic DVT. Whatever we do, all the tests on earth, if you do, you can diagnose only 50%. So rest of the 50% are termed as idiopathic DVT. So he should be definitely having a cause which we have not still found out. For example, before 20 years, 30 years, we did not know APS, a disease at all called APS. But now we know APS can produce venous thrombosis. So like that, there are many things which we do not know. So I think the patient should have a long-term anticoagulants for an indefinite period and continue antituberculous treatment. And rivaroxaban, I thought that Parvati told that she belongs to a lower economic group. There are Indian varieties of rivaroxaban, which you can get it for about 15 rupees. So that may be tried if you're giving the original one for the patient's economic reason. I think this is also working well. So these are the things that for the comments. Sharma, anything to?
Can I say one word?
Yes, Suma. Thank you very much.
Thank you, Matthew Thomas sir, Sharma sir, and Sanjeev Nair for the excellent discussion. And I would also like to congratulate Parvati for a very good presentation.
Yes.
Even though in between she was some questions she was not answering, but if you take the whole thing, it was an excellent presentation. And I am sure, and actually the purpose was that I wanted that she should err somewhere, so that you will be asking too much questions and she'll be learning from that. So I'm sure she'll go and start reading that portions again and again, and she'll be improving, and also her fellow PG students who are listening to it. Excellent discussions, sir. I'm very thankful to you, and depending upon that, she'll be correcting the management also. Thank you, sir. Thank you.
One more word from my side. Parvati, you have done very well. Congratulations. Keep it up in the future also. Thank you.
Okay, Parvati, we all think that you have presented well. It's a very difficult case, and I think you have got about 60 to 70% of the questions answered. And you have to change your way of writing the case sheet, bringing back all the diagnosis after the investigation. So it was a very good presentation. We'll go to the next case.
Thank you,
Ibrahim
sir.
is ready. Ibrahim.
Yeah.
Share the screen now, sir. Sir, is it visible, sir?
Yes, visible.
Yes, sir. May I start?
Yes, you can start.
Respected faculties and my dear colleagues, I'm very much honored to be able to present in this platform, and I'm very grateful to my teachers here at Alpera Medical College to be able to present this. And today's my case is a curious case of a headache, and then my patient is Miss XYZ, a 34-year-old female who's a housewife, and she hails from Alpera. Her presenting complaint was that she presented with generalized body ache for 6 days duration, fever of 6 days duration, headache of 5 days duration, and vomiting of 1 day duration. History of present illness: she was apparently normal until 6 days back and then started that fever. That fever was one of insidious onset, low-grade fever, which was present throughout the day and showed no diurnal variation. It subsided with antipyretics and recurs without them. It was associated with generalized body pain and chills. The headache was holocranial. It was a dull, aching type of pain, which was gradual in its onset but progressively worsening. It was severe intensity at presentation, and it was associated with retroorbital pain upon questioning for it. She also had difficulty to look at bright light. She had difficulty to look down due to worsening of the neck pain that she had. This headache had also occurred intermittently, and it was worsened by movement and light. Headache worsened gradually over the next few days, and now she could not even fall asleep due to the pain. About the vomiting, vomiting started with the day of presentation to the casualty. She had one episode of vomiting, which was non-projectile, and the vomit is considered of Foley foot particles. Upon questioning, we found that there is history of exposure to dirty, stagnant water, but I could not find any history of cough or breathlessness, or dysuria or abdominal pain, no history of blurring of vision or diplopia. There is no history of worsening of headache with coughing, sneezing, or straining. There is no history of aura, altered sensorium, or seizures, no history of joint pains or rashes over her body, no history of weakness or any part of her body, or abnormal or absent sensations, no history of redness of eyes, colored halos, lacrimation, or autonomic symptoms. In her past history, there is history of migraine since 15 years of age, and she takes over-the-counter analgesic for relief, which is paracetamol. But this time, the pain she describes is of a different severity, quality, and frequency. There is recent history of left mild hydrouretronephrosis, secondary to distal ureteral calculus. But there is no history of similar illness in the past, nor there is any history of diabetes, mellitus, hypertension, dyslipidemia, tuberculosis, or malignancy. In the family history was unremarkable, and there is no family history of headaches or history of any similar disease. She's married and has 2 children, apparently healthy and normal. Personal history was unremarkable except for the disturbed sleep that she's having. In the menstrual and obstetric history was also within normal limits. Socioeconomic status was poor. And the summary of my history would be a 34-year-old housewife, known case of migraine, presented with complaints of fever, myalgia of 6 days duration, holocranial dull aching headache of 5 days duration, associated with photophobia, retroorbital pain, neck pain, non-projectile vomiting for 1 day duration.
Okay, Ibrahim, it's a very good summary that you have given, and the main focus is headache. So definitely we'll be just asking you how to approach a patient with headache when a patient comes to you.
So when a patient comes to us with the complaints of headache, we should actually think about the causes of the headache that the patient may be having. It could be a primary cause of a headache, or it could be a secondary cause of headache. Mostly the headaches are secondary causes, and primary causes are also there. Yes, definitely. And depending
What
on
will
the
be
age
the
of
rough proportion?
the
What will
patient's
be the
age,
rough
and
proportion? Ibrahim, what will be the rough proportion of this primary headaches and secondary headaches? Supposing you see 100 cases consecutively, how many you think will be secondary,
yes,
or how many you will think will be primary headaches?
10:90 maybe, sir. Maybe
Okay,
9%.
we will leave it to James. James will note this point so that we can discuss later. Go on.
Yes, sir.
Then, so what do you think about this patient? Do you think it's a primary or a secondary headache?
Sir, this could be a primary headache, which is actually precipitated by the fever. She's a known case of migraine.
So
And
primary
infection is known.
headaches are very few in number, is it not?
Yes, sir. But she is a case of migraine, and there is history of fever in this patient. So it is quite common that fever or infections can precipitate an attack of migraine. So it could still be
Okay.
a
Can
case
you
of
give some examples of secondary headaches, common causes?
secondary headaches may be due to sinusitis, sir. Paramecium infection.
Go on.
A cause of systemic illness, like any sort of systemic illness, like a urinary tract infection can cause it.
Yes.
Pneumonia can cause it. So it could be even.
Okay. Now, apart from infections, you go to non-infectious conditions.
Non-infectious causes. No, yes, sir.
Have you heard of systemic hypertension?
Yes, sir. Definitely.
Yes, you have to tell common things. Common
Yes,
things should be answered first. Yes, come on, still some more.
Systemic hypertension, malignancies.
Malignancies.
Yeah, like
you'll have to think of a brain tumor.
Brain tumor.
Okay. Then
other causes like dehydration.
Any systemic fever, acute viral infections can bring about. I think James will be talking to you more about this. So what are the primary causes?
So primary cause may be migraine, or it could be cluster headache.
Yes.
It could be trigeminal autonomic nephralgias.
Yes.
Then SUNCT, SUNA, and
yes. Secondary causes, there are so many causes like subarachnoid hemorrhage, CVA, so many things. So what you said is correct. Secondary causes are more common. Primary causes are less. Now, how this patient you think of a primary cause?
Yes, sir.
Okay. James, can you? James, can you?
Yes, sir. Ibrahim, one question. In this particular scenario, you see that a patient is having migraine, patient is having fever, myalgia and systemic symptoms, then headache. What is your approach to this patient? Approach means what are the possibilities in this case?
Sir, this could be, as I said, it could be a primary headache, which is precipitated by an systemic illness or a fever. Or it could be a secondary headache. So if it is a secondary headache, then I need to think about the causes of the secondary headache, which in this case, since the patient is having a fever, I should think about an infectious cause and also non-infectious causes, but most commonly an infectious cause. And if that is the case, then the infectious cause, then she's having myalgia, then fever, myalgia, and then headache. So I can think about the common infectious agents here, like it could be sinusitis, it could be it could be even meningitis, since the patient is having a photophobia and neck pain. It could be a UTI, since there is history of left hyoid nephrosis in the patient recently with the distal calcium. I can think about that in this patient.
Okay. Okay, right. Very good. Very good. I will say that your approach should be a bit more clear,
yes,
rather than thinking of all the causes of secondary headache.
Okay.
You should have a primitive, a preliminary splitting. Three things you have to consider in this case. The first is whether a patient is having a migraine. In the background, there is a migraine. Whether the migraine is aggravated or precipitated by a infection. That is the first concern. If it is a migraine precipitated by the fever, what should be this migraine called? At this time, what will you call this migraine? If you don't know, you just tell me so that we will.
I don't know, sir.
You don't know. See, the migrainous headache, there should be a fixed period. What is the period in which migraine can last?
4 hours to 72 hours. Sir.
72 hours. 4 hours to 72 hours, patient can have a single migraine attack. Here the migraine headache for 5 days. Then what is it called?
Status
if you don't know, you just tell me. I don't know.
Status migrainosis.
Status migrainosis. Very good. Very good. So you should have an idea that this could be a primary headache, and a status migrainosus has precipitated by the fever. That should be your first thing. The second thing which you have to consider is patient is having fever, myalgia, so many retroorbital pain, neck pain, etc., and vomiting, non-projectile vomiting. So patient is having a systemic infection, and a systemic infection has produced a headache, isn't it? You see that a patient is coming in the casualty for viral fever or so, they will say that fever, dengue fever, intense retroorbital pain is the main feature. So it could be a viral fever with a headache as a manifestation of fever. That should be your second thing. Third thing is there is a systemic infection which has involved the CNS as a meningitis or a encephalitis or infection of CNS. These are the three ways by which you have to approach this case.
Yes, sir.
Did you understand?
Yes, sir.
Then the next steps will be very easy. I am emphasizing is not as an examination, but sometimes in what happens in the casualty, the most important, difficult thing is to differentiate whether a headache is produced by the fever itself or whether the headache is produced by a additional CNS involvement. That should be the approach. Okay.
Yes, sir.
Sharma sir?
Yeah.
Okay.
yeah,
Sharma, anything to?
Is the onset, how was the onset? Gradual?
Yes, sir. Gradual, sir. Insidious, really.
Have you heard the term thunderclap headache?
Yes, sir. Yes, sir.
Where do you get it?
Sir, thunderclap headache may be seen in subarachnoid hemorrhage, reversible cerebral vasospastic syndrome, pituitary apoplexy.
Okay. Agreed. Enough. 3 are enough. Then if it is holocranial, tell me some cause of a unilateral headache. Only one. 2, 3 common causes.
Sir, migraine headache.
Yes. Some other organ producing headache, radiating.
Temporal artery.
Temporal artery can be unilateral or bilateral. What about eye?
Yes, sir.
Sometimes the patient comes with a severe headache, unilateral predominantly, then vomit, then glaucoma, acute congestive glaucoma. Anything else, more innocuous thing, but I have seen patients going for a CT and all that, not from the intracranial cavity, somewhere else. Dental pain, patient will come with the pain in the radiating pain, and Without examining, you can do a CT. Therefore, it's a unilateral. Onset is very, very important. Are you following it? Any blurring of vision the patient had?
No, sir. No blurring of vision.
No. You said about classical migraine. What? Just tell me the aura. What is that? Can you describe the aura?
Sir, sir, aura is the symptom that the patient will experience before the onset of the headache. It could be mostly they are visual aura the patient sees. Silver blurry lines, zigzag lines are seen by the patient.
Okay.
Ibrahim.
Yes, sir.
See, always a sir has asked, the problem is whether an aura is a TA or a seizure, isn't it? When a patient is developing a visual field defect or something like, or a numbness of hand, you may consider whether it's a TA or whether it's a migraine aura, or it's a seizure. So there is a duration in which the migraine aura evolves. What is that duration which should be taken to evolve a migraine aura?
I don't know, sir.
It should evolve, it should take more than 5 minutes. It should not evolve less than 5 minutes.
Okay.
How long a migraine aura can last?
I don't know, sir. Even
up
after
to 60 minutes. If it is lasting for more than 60 minutes, it is you should be on red alert. And headache should start before or after?
Headache after the aura?
Usually after. How much after?
5 minutes.
No, within 60 minutes of starting of the aura. Then only it will qualify as a aura.
Okay.
One more question to you. In classical headache, everybody teaches red alert signs of headache, red alerting signs. Can you enumerate some,
yes,
some red alerting signs of headache?
Yes, sir. Headache with focal neurological deficit, headache with which is onset after the age of 50 years.
Oh.
A thunderclap headache.
Thunderclap. First, you should say the first and foremost is thunderclap. Thunderclap. Okay.
Yes, sir.
Fever with headache.
Sir.
That also is a red alerting sign. Worsening of the frequency.
Yes, sir.
Nocturnal awakening.
Yes, sir. Nocturnal awakening. Worst headache.
What is meant by thunderclap headache?
Thunderclap headache is felt by the patient at sudden onset. The worst type of headache that the patient will be.
That is not the specific feature of thunderclap. It is sudden, and one more adjective that is a must. It is a sudden, and the headache is maximum at the onset. Then only you can call it as thunderclap.
Okay.
It is a sudden. It is maximum at the onset. Thunderclap.
Yes.
Can you tell? Sharma sir has already asked you what are the causes. So Matthew Thomas sir.
Continue with the physical examination.
Okay. So from the differential diagnosis, I got from history that migraine which is preceded by fever. It could be a secondary headache, which is infection related. Could be due to a dengue fever, leptospirosis, urinary tract infection, or even meningitis.
So I will say that your differential diagnosis should be 3. One is migraine precipitated by status migrainosus.
Status migrainosus, yes, sir.
A secondary headache due to an infection related, and the third should be an infection of the CNS.
Infection of the CNS.
Infection of the meningitis. Instead of saying meningitis, you should, as the third cause, you should put it as infections.
Infection of
that should be the
James, you could add my doubt of how many, what is the percentage of primary and secondary headaches that a physician sees?
Actually, it is said that about 2/3 of the cases of headaches are primary headache, and 1/3 is secondary headache. That is the usual statistics which is described.
So, but that is
But
not seen practically.
There is no Indian statistics. That is the problem.
We see a lot of cases which are secondary.
Exactly, sir. That is what I was saying. Because if you see from the physician's point of view, secondary headache may be more. But
Yes.
one thing is that if you read the primary headaches now, under the tension type headache, a broad category of the headache will come. That is why it comes as studies. Because most of the headache Western people are saying is tension type headache. That comes down, where the infections and other things are less. That may be the reason. But I think that statistics may not be correct from the view of Indian physicians seeing a case. I think the ratio may be.
But I do agree that tension headaches we are seeing a lot. So that proportion may be nearing that 2/3 or even a little less than that. So 2/3 means 60%. So maybe 50%, 40% we can put it as primary headaches. Okay, James? Okay. Okay. Sharma, എന്തെങ്കിലും പറയാനുണ്ടോ? Sharma?
Ibrahim,
the most common headache I happen to see in consultation is the tension vascular headache. Tension vascular is the most, I think, most common in my practice and the physician's practice. Very, very common. And everybody gets amitriptyline or amitriptyline, those things, and they improve.
So Ibrahim, this approach is good. Your differential diagnosis, we all agree. And I asked you to add the third one because in every cases like this coming in a casualty, that should be your thinking process.
Yes, sir.
Okay, now proceed.
Proceed.
Yes, sir. On examination, the patient is conscious, oriented, cooperative, and obeys commands. She's
Again, to make it short, Ibrahim, tell the positive findings only. Okay.
Yes, sir. There were no bruit. Her temperature was high, 100°F. Respiratory rate was normal. And upon general examination, I found that there is conjunctival injection in both eyes. Apart from that, there is no pulmonary clubbing, sinus, or generalized lymphadenopathy. She was in severe pain at time of examination. She had tearful eyes, but no purulent discharge was noted from her eyes. There are no neurocutaneous markers, no rashes or eschar noted anywhere on the body. No calf muscle tenderness was noted. The scene of examination, higher mental functions.
Ibrahim,
yes,
one more point.
Yes, sir.
Patient is having severe pain all over the body, isn't it? Then I think that not only calf muscle tenderness, but tenderness of the other muscles are also important.
Yes, sir.
Sometimes you may be dealing with a leptospirosis, where the muscles may be very tender.
Very tender.
Or you may be dealing with a what is called a tropical, what is that? Tropical myositis, isn't it? Myositis. They are in the initial stage, patient may come with fever and severe muscle pain. Or such conditions, you have to consider. Sometimes some infections, dengue fever also will produce the same picture. So you have to palpate the muscle, feel the muscle, and see whether there is a tenderness and whether the tenderness is localized, which is specific for certain muscles. So why did you specifically look for calf muscle tenderness?
So usually we see calf muscle, generalized muscle tenderness will be there, but we usually elicit the calf muscle.
Why it is so? With every case, you have to change your strategy, isn't it?
Yes, sir.
Where will you specifically look for calf muscle tenderness?
What condition?
What condition?
DVT, sir.
Yes.
Is it safe?
You should answer that.
No, sir, it's not safe. No, sir, it's not safe.
It's not safe. So stop the practice of routinely checking calf muscle tenderness. Okay.
Yes, sir. Yes, sir.
Go on.
In CNS examination, higher mental functions were within normal limits. Clinical functions were done. They were all normal. A fundus examination was done. No papilledema, normal fundus. And the pupils were also normal. And motor system examination also revealed normal findings. No primitive reflexes. In sensory system examination also was within normal limits. There is no history of suggestive of any autonomic nervous system involvement either. When checking the signs of a meningeal irritation, I found that patient was having neck stiffness. It was initially a terminal neck stiffness that the patient was having, but upon further examination in the ward, she had a complete neck stiffness. Kernig sign was...
Ibrahim, one question.
Yes, sir.
What precaution will you take when you check neck stiffness? We cannot demonstrate now. Tell us, how will you check neck stiffness? What should be your precautions when you check neck stiffness?
Precautions.
If you don't know,
No, sir, I don't know, sir.
You don't know why. You are every day. The thing is nothing more. The most important thing is patient will be usually lying with a pillow under their head.
Yes. Yes, sir.
And usually we start looking from the pillow position.
No.
What you have to do is to get a full movement of the neck. You have to
Fully extend her neck.
take off the pillow, then check the neck stiffness. That is the first one. Second one, many patients with neurological illness or other metabolic illness may have stiffness of the neck, cervical spondylosis.
Yes, sir.
Stiffness of neck or Parkinsonism, stiffness of neck. Some metabolic diseases can have stiffness of neck, which is not meningeal irritation. To see whether it is a generalized stiffness of neck, before knowing neck stiffness, you have to move the neck in other directions to see whether it is having resistance. These are all very simple things. When we are asking questions, examiners are asking questions, don't think that they are very rare. We expect very rare or things which you are not knowing. We are asking questions which are very common to highlight the things.
Yes.
Salim, and one more from my side. When you examine for neck stiffness, the patient will be supine or any other position. What is the better method of eliciting neck stiffness?
Sir, sitting position.
Sitting position, that is better, because when you are doing the neck stiffness, you are stretching the meninges. Okay. When you are doing the Kernig sign, you are stretching the lower roots and all that. So when the patient is sitting with the knee straight, you are already doing it and you are bending from the top. So both combined together, it gives a better sensitive method. It is given in the Nelson's pediatric textbook, and I also experienced. What is James' experience? Do you recommend that as a neurologist?
Definitely, sir. Checking it in a sitting position is
if the patient can.
Very sensitive. But sometimes what happens is patients will be too sick to examine.
Yes.
Agreed.
Yes.
It's a very sensitive method.
Sensitive method. So there are articles for that, because you are doing both together. From above you are stretching, here or lower also you are stretching. And many students will say that there is no neck stiffness. Ask them to go and check in the sitting position. Then the neck stiffness comes. Then you do the LP. You find cells there. Therefore, if possible, as Dr. Matthew Thomas said, if possible, make the patient sit up and then do it.
Yes. Go on.
Proceed.
Go on, Ibrahim.
Yes, sir. Yes, sir. Other systems were within normal limits, sir, except for per abdomen examination. It's revealed a soft, mild hypogastric tenderness. No renal angle tenderness was noted. Examination of ENT was within normal limits.
Did you examine the fundus?
Yes, sir. Fundus was examined.
He said it's normal. No papilledema. He said completely.
Okay. Off the label, I shall ask you. I shall tell you. In this COVID era, it is a bit risky to have examination of the
fundoscope.
Practically,
correct.
Because you should be very careful how to protect yourself. So, cases where you require a fundal examination is absolutely necessary. You can send them to ophthalmology, where fundal photograph can be taken and you can examine, because you have to protect yourself in a situation of.
Correct.
Sir, I only did it after the RT-PCR test was negative.
Okay, that is also good. Okay.
That doesn't rule out. Still, the patient can have it.
Okay, continue.
Yes.
So you're summarizing the history and the physical findings.
Yes, how the patient came into the casualty and how we decided to evaluate her. So the patient was a patient with a history of migraine, came walking into the of severe headache associated with vomiting and mild fever. She was given analgesic when it was observed. Pain did not subside even with a different analgesic. We found neck stiffness in the casualty. A CT head was done. No significant abnormalities were noted, and she was admitted for further evaluation in the ward. At that point, the clinical diagnosis was a community-acquired meningitis, possibly a pyogenic meningitis, along with a UTI.
See, from the history and physical examination, your diagnosis is meningitis, isn't it?
Yes.
Why did you say it is meningitis?
Sir, the patient had the triad of meningitis in the symptomatology: headache, fever, and vomiting. And also, she had other findings of, she had photophobia, and she had the neck pain. On examination, there was neck stiffness. So that
Is it okay, agreed. If it is a meningitis, is it a viral or a bacterial or something else, something other infective meningitis?
So the
You said viral, isn't it? Pyogenic.
No,
you said it is pyogenic.
Yes, sir. Right. I said
Why
it
did
is
you say it is pyogenic meningitis?
Sir, I said so because in this patient, the most common cause of meningitis and that community-acquired meningitis.
No. The common cause is not pyogenic.
Yes, sir.
It may be probably viral. Huh?
Okay.
What is there should be, when you make a diagnosis that is a pyogenic meningitis, there should be a solid point. Otherwise, I shall tell you frankly, I cannot say whether it's a viral or a pyogenic. It's only 5 days duration. I cannot say whether it is, I cannot exclude tuberculosis also, isn't it? So there are inabilities in clinical medicine, and we have to adopt that, we have to admit that inabilities. That is why I asked, is there any solid point to say at this stage this is a pyogenic? We cannot.
No, sir.
The answer is I cannot. I don't know. Anybody else is Sharma sir, any clinical?
No. I will just say meningitis only because there is neck stiffness.
Sir, what is your opinion?
Yes, same thing. I think if he has some nasal stiffness or influenza-like features, and then this probably viral, something like that. Something.
We can say we have to admit our inabilities in clinical medicine, and we can say that it's a meningitis.
Meningitis.
Why
Correct.
it is not an encephalitis?
Sir, in this patient, there is no history of any altered sensorium or seizures. No altered behavior.
Correct.
Yes, these are not.
Very good. I agree that this is not unlikely to be an encephalitis because there are no feature of an encephalon involvement like a seizure, altered sensorium. Very good.
Okay.
UTI, urinary tract infection.
Sir, I kept that because there was mild hypogastric tenderness in this patient. And
you said other systems are normal.
No, he said there is hypogastric tenderness.
Hypogastric, there is generalized myalgia, and abdomen is constituted by muscle. So hypogastric tenderness could not be taken as a fact. See, our diagnosis and our steps should be on firm ground. Suppose patient was saying that there is dysuria.
Is there any dysuria?
Urinary tract infection will be associated with the chills and rigor, isn't it?
Chills and rigor. Dysuria should be there. Patient is conscious. She'll be able to say that. Without that, you cannot put UTI.
Okay. Why should you unnecessarily put the UTI when for the abdominal tenderness you have another explanation, myalgia? I cannot say at this stage there is urinary infection unless otherwise, Sir has said it should be a high grade fever with dysuria and all. Frequency, nothing is there. Frequency should be there, dysuria should be there, high grade fever and should be there. There should not be any myalgia also. Isn't it, sir?
Yes.
They develop myalgia, severe myalgia in urinary infection. I don't know.
Okay, you continue, Ibrahim.
So baseline.
So what are the investigations you undertook?
Yes, sir. On admission, baseline investigations were sent, and most of them were normal except for this high ESR that we noted, and there is also elevated SGPT in this patient.
Okay.
And in the course in the hospital, she was started on ceftriaxone 2 gram BD analysis and supporting measures and fluids. She was given cyclovir on day 2 of admission since she did not show any signs of improvement. CT brain was also within normal limits. Lumbar puncture was done on day 2.
Ibrahim, one question.
Yes.
Do you think
Yes,
that acyclovir is indicated?
Yes, sir. I cannot rule out viral cause.
No problem. Empirical treatment on the first day can include acyclovir. But after the LP next day, you should
stopped.
There are a lot of issues with the medical legal issues. Unnecessarily administering medicine. As in the previous case, suppose a patient is having some problem with the acyclovir, they will argue that it is an unnecessary thing. The standard is on the first day, empirically you can start that. Okay. Proceed. Okay. First.
So lumbar puncture was done. A clear CSF fluid was drained. Opening pressure was 160 millimeters. Samples were sent for investigation. USG abdomen was done. No significant abnormality was seen. Patient had intermittent severe headaches in the initial few days of admission despite treatment. The CSF study returned 60 cells and all of them were lymphocytes. Sugar was 57. RBS was 97 at that time. Serum ADA 4.4 normal. Albumin.
Keep that slide for 1 minute, 1 second.
Yes,
TC is 60. All are lymphocytes. Sugar 57. ADA 44, 4.4. Albumin 285. Protein 58. CSF study is abnormal. Non-specific viral carcinomatous. See, what is CTD?
Connective tissue disorder.
Connective tissue disorder.
Sorry. At this point, working at a stage again. See, what is
the
this
whole
CSF? Frankly, what is this indicate?
Sir, it indicates that it indicates a viral picture, sir. A viral infectious etiology. Or
what is the firm point to say that it's a viral?
Sir, predominantly lymphocytic picture seen, and there is also
lymphocytic picture can occur with the early tuberculosis, isn't it?
Yes, sir. But the sugar is normal, sir.
Sugar, that is the thing. We all ignore sugar and go after protein. Right? Actually, sugar is a very good indicator of the direction of meningitis, because tuberculosis, fungal, and bacterial, pyogenic, the usual one will produce a sugar which is very, which is on the lower side. And carcinomatous, it will produce actually the lowest level of sugar in carcinomatous. So at this level, the differential diagnosis, the first one should be viral. I agree that is viral. Carcinomatous won't come because you have to correlate with the clinical picture, isn't it? It's an acute event with fever and all. So carcinomatous, I don't agree. Connective tissue disease, okay. As a general medicine side, you may have to, sir, isn't it? Matthew Thomas,
okay.
You may be happy.
Okay. No, let him continue. Continue.
At this point, working diagnosis change. That's why I told you that at this stage, working should not change. First time also you should have said that it's just meningitis.
Yes,
now it has become a viral
meningitis. Yes, sir. Viral meningitis. After 4 days of treatment, she showed lesser frequency and intensity of headaches. New lab results came positive, and this is how my case of headache has become curious, sir. And serum IgM dengue turned positive for this patient. Also turned positive was serum IgM leptospirosis, which also turned positive and was highly positive initially. The OTPT and ALP levels were falling by now after 5 days of treatment. So this is not purely a CNS disease. This could be a CNS manifestation.
Ibrahim,
let him finish, James. James, let him finish. Let him finish. Okay.
So I believe that this is now not purely CNS disease. This could be a CNS manifestation of a systemic disease, since there is also liver dysfunction that is present. So this could be either leptospirosis or dengue, or it could be a co-infection.
Ibrahim.
Yes, sir.
At this stage, what do you think? Is it the dengue which is likely, or whether it is leptospirosis which is likely?
Leptospirosis.
Why?
Because the titer is highly positive for leptospirosis and less
what
for
size?
the titer for IgM titer is highly positive for
Both the IgM is
leptospirosis.
there, isn't it? There is another indicator
Yes,
investigation which may suggest leptospirosis.
Yes,
What is it?
the transaminases, the OTCP levels
Transaminases
are
can occur in dengue, isn't it? I don't know.
both.
Yes, it can.
Yes, sir. Can occur in both.
The thing is, what I want to tell you, what is the ESR?
Yes, sir. The lesser ESR was 135, sir.
Is it favoring a
High, yes, sir.
leptospirosis or dengue?
That favors leptospirosis.
That is why I asked whether it is okay.
What is an anamnestic reaction, Ibrahim? Have you heard of an anamnestic reaction?
Yes, sir.
In bacteriology, is there something called anamnestic reaction?
Yes, sir. I don't remember.
See, you can get positive, but there may be a cross reaction of the cross reaction, and there may be only one infection, and the other antibodies may interact. For example, in this patient, they may have she may have leptospirosis, and positive dengue may be an anamnestic reaction. So that is very often seen. We see 2, 3, 4 infections like that together. Okay, continue.
Okay, sir. Other CSF reports were within normal. Culture sensitivity was normal. TB PCR was normal. Gram stain did not reveal any organisms, nor did AFP stain. MRI brain was done. It showed only non-specific findings. No other significant abnormalities were seen in the present study. No leptomeningeal enhancement. This is also consistent with aseptic meningitis. A neurology opinion was sought. Clinical features suggestive of a neurological manifestation of a systemic disease, leptospirosis or dengue fever. They suggested the same mode of treatment in this patient. And while on treatment, a progressive worsening was noted. Generalized symptoms in the form of myalgia and malaise worsened, and the patient had to be shifted to the ICU. And there we sent blood for routine hemogram, which now showed leukopenia and thrombocytopenia. But total count fell from 9,800 to 2,500. And this, we took a clinical clue that the manifestation could be related to a dengue fever, since there is thrombocytopenia. But still, the leptospirosis could also be the reason.
Was there anything you can do for a PCR of leptospira? Is there any lab which does?
Yes, sir. Yes, sir. Yes, sir. Eventually, we are coming to that.
Okay.
By this time, other reports had came. The serum ANA profile done was negative, but the serum IgM scrub was done for the patient, and that turned positive. Wheel-Felix reaction or XK turned positive. And the serum IgM dengue and leptospirosis was repeated, and they show a rising titer of IgM dengue antibody. So again, this is highly suggestive of a neurological manifestation of a systemic disease like dengue fever. The pictures are turning towards dengue now more than that of leptospirosis. And to confirm the diagnosis, we sent a CSF sample for leptospirosis PCR, which turned negative, and dengue PCR turned positive. And finally, the diagnosis changed to neurological manifestation of systemic disease, dengue fever with meningitis. And the take-home message from my little presentation.
What happened to the patient? And you say, Ibrahim, you tell us what happened to the patient, and then you say your take-home message.
Yes, yes, sir. Yes, sir. So the patient, she eventually recovered, and she came back to the ward. And in the ward, we continued treatment with supporting measures. She improved after 4 days of treatment, and on 5th day after ICU admission, she was discharged. And now, recently, I called her like 3 days before, and she's now well and happy. She occasionally has those headaches, which she attributes to the migraine. Apart from that, she's quite okay now.
Ibrahim, one more question. What will be the peripheral blood manifestation in a case of leptospira?
Sir, leptospira, we can see a hepatorenal picture, sir. The transaminitis.
No. Just a routine blood examination. That's what I am asking.
Routine blood, sir. Sir, there can be leukopenia.
Leukopenia, leptospirosis? No.
Leukocytosis, sir.
Leukocytosis, polymorphonuclear
polymorphonuclear
leukocytosis.
leukocytosis.
Leukocytosis with the high ESR.
High ESR.
Dengue or viral?
Thrombocytopenia, sir.
Normal leukocytes with the possibly
normal.
TC will be almost in the normal range. There may be a leukopenia and ESR will be?
ESR normal.
Usually normal. Isn't it, sir?
Yes, correct.
ESR is usually normal. Here, ESR is high and TC is normal, isn't it?
Yes.
What about the LFT, Salim? What is the LFT in leptospira?
Sir,
usually found.
LFT is deranged, sir.
No, what type you get classically? Type of
what will be increased? Which transaminase will be increased?
SGPT, sir.
SGOT
and SGPT will be elevated.
Which will be more?
Both of them will be elevated.
No, SGOT is usually more than SGPT.
And SGPT,
more than
how much
PT.
does it go up? How much up to which level usually goes up? SGPT. It usually goes around less than 200, doesn't go to much level, like viral hepatitis. What about the bilirubin? What type of bilirubin, what type of jaundice you get? What type of jaundice? It is cholestatic jaundice. Cholestatic jaundice. You get conjugated hyperbilirubinemia with moderate elevation of alkaline phosphatase. That is classical of lepto. Okay.
Ibrahim, what is your explanation for that positive leptospiral test IgM?
I told you it's an anamnestic reaction.
Anamnestic reaction.
You didn't read about it, Ibrahim.
So my doubt. Many. Okay. Sir, I have a doubt whether both can exist together. That is, there is a leptospiral infection, there is a dengue infection, and the dengue infection has caused the CNS manifestation. Is it possible?
It's possible.
Possible. In such a case, the renal, usually it is a hepatorenal. There will be some abnormalities in the creatinine, at least 1.5, 1.6. It doesn't happen here. It did not happen here.
That can also produce lymphocytic meningitis, lepto. Both can produce.
Yes.
We are seeing a lot of lymphocytic meningitis in a lot of once in a while we used to see meningitis are admitted in neurology, meningitis cases. And from here, seeing this high CPK, myalgia, leukocytosis, and high ESR, we are thinking leptospira, and the diagnosis is coming as leptospira.
It's actually an aseptic meningitis, immunological even.
It's an aseptic meningitis. It's not pyogenic.
Yeah.
It's a lot of immunological reactions happen in leptospirosis. Yeah. It has got a second phase called immunological phase. So what is your take-home messages, Ibrahim? You presented something. Let us hear. Let us see that. Okay. Read.
Any systemic disease can present as isolated system disease in the form of neurological, pulmonary, or hepatic or renal disease. Any systemic disease can have autoimmune antibodies of different spectrum in the form of antibodies of connective tissue disorders, anti-thyroid antibody, or any other antibodies. An anamnestic reaction, just like you said, sir. In endemic areas, mixed infections are common, which will cause positive IgM levels of those organisms in blood, even if asymptomatic. So, like leptospirosis in this case, for example. So,
so finally, what is your diagnosis? Leptospirosis, dengue meningitis.
No, he said only dengue fever.
Yes,
because PCR is negative. PCR for leptospirosis is negative.
Yes, sir.
Dengue fever with meningitis. That is your diagnosis.
Yes, that will be the diagnosis. What are the other neurological manifestations of dengue fever described?
Sir, encephalitis, dengue,
Yes.
encephalopathy.
Encephalitis. Anything else? We have seen Guillain-Barré syndrome. We have seen Guillain-Barré syndrome proved to be dengue. James, varanye baki.
Most of the, apart from the direct infection is usually aseptic meningitis. Usually aseptic meningitis, and rarely encephalitis also. So meningoencephalitis is the commonest direct invasion.
Yes.
And it is usually a lymphocytic one with normal sugar and normal protein. The next manifestation is most of them are post-infective problems. Post-infective problems, they can present as ADAM. ADAM is a well-known complication, and sometimes it could be a site-restricted ADAMs like a transverse myelitis. And as Sar has said, Guillain-Barré syndrome is also known. And in many cases, the usual Guillain-Barré plus a variant of Guillain-Barré which is called Aman is also described with the.
What is it? What is it?
And
Aman means pure.
Okay.
Pure.
Aman Amsan.
No.
Sir, 2-3 questions chat box. Chat box.
Paranyo, chocho.
Cervical spine stability. Ipo headache in the then meningismus. Then next stiffness and next stiffness occurs only in basal meningitis, not in otitis meningitis. This is Dr. Balendra, sir. Opinions.
James, paranyo.
What is the question? I didn't.
There are one history level cervical spine stability.
No.
Next stiffness cervical spine stability.
It's not stability, but what you have to do is you have to check the resistance to movement in other directions also, like extension, lateral movement. If there meningismus is a non-specific term. When a patient is having a systemic problems, like sometimes herniation of systemic problems like viral fever, or when there is a para-infectious problem, like infection in the neck without involvement of the meninges, you may develop a mild neck stiffness when you clinically examine. But CSF will be normal. Then that is called meningismus.
Then neck stiffness occurs only in basal meningitis, not in otitic meningitis.
What is that? Otta?
I did not.
Otic meningitis.
What is that, sir? Otic?
Dr. Balendran sir has written neck stiffness occurs only in basal meningitis, not in otic meningitis.
I don't know. Okay. Any other questions?
I'm not aware of that term.
Matham, sir, I have a question to Dr. James. This is the terminology that new daily persistent headache.
There is something like that.
Yeah.
New.
Is NDPH.
Is it? Yes. New daily. Chronic headache.
Headache.
Daily persistent
following dengue fever.
Persistent headache.
Common.
DPH.
Or do you use that in practice, or do you see that like that? It is NDPH, new daily persistent headache, usually following dengue infection.
The definition of new onset daily persistent headache is if a person is developing headache, the duration of which is more than 3 months, or less than 3 months, the duration of the headache is less than 3 months. And if the patient is having headache at least 15 days per month, that headache is called NDPH.
What are the causes?
The total duration of headache should be less than 3 months. And in each month, patient should get a headache for more than 15 days per month. When it is coming in that category, it is coming out as NDPH. NDPH is a very non-specific term. NDPH is a very non-specific because under that primary headache is also coming. Your migraine may sometimes come under that. Secondary headaches can come that. Usually this NDPH is used to denote diseases like postural, this one, intracranial hypotension. Whenever there is an NDPH, the literature says that you have to look for a low pressure, low CSF pressure headache. But the term is very non-specific. Even this headache, if it lasts for more than 15 days, you can include under NDPH, new onset daily persistent headache, which is less than of 3 months duration, which is present for at least 15 days in a month.
So you don't have to be much worried about that. That's right.
Why?
Alala, it is because it's not specific for dengue. Lot of causes could be there.
It is not specific for dengue. Dengue can have this headache usually in literature or usually in neurological platforms. NDPH, if there is an NDPH indicate you have to exclude a low pressure headache, low CSF pressure headache. That is, but it is very non-specific. In its classification itself, it is classified as primary and secondary. Primary means even after extensive headache, even after extensive investigation, you don't find any cause, then it is called primary. So any secondary headache can present as NDPH.
Okay.
James, sorry, question good. James.
Sir, one more.
James.
That
James, is there any objective method to find out pain in the body?
There is no objective means to assess pain. No objective. No objective. But in research studies,
respect study
nothing. No study can quantitatively measure that this is your pain, this is you have pain, or you don't have pain at all.
So we can make a lot of mistakes, is it not, doctors?
A lot of mistakes. One more thing I want to add, for studies, there are, when you design some drugs like gabapentin for pain or some drugs for pain, there are means to clinically assess the pain. Clinically assess the pain, there are grading of pain. That they are all subjective.
Subjective objective.
There is no objective means as far as I know till now.
Okay. Otitis meningitis is an infection in the middle cranial or anything cranial fossa. Neck stiffness occurs with sensory field of C2, 3, 4, 5 supply basal meninges. Sensory supply to meninges is from C3, C4, C5. It's from Dr. Balendran.
Can you read once more?
So, otic meningitis is an infection above in middle cranial or anything cranial fossa. Neck stiffness occurs since sensory field C2, C3, C4, C5 supply basal meninges, and sensory supply to meninges is from C3, C4, C5. And you can get a reflex spasm of neck muscles. And someone has told he might have meant otitic hydrocephalus.
Because this is the term which is we usually see. Sharma sir, are you accustomed to this term, otitic?
And another doctor has given infection of the meninges secondary to otitis media or mastoiditis is otitic meningitis.
Actually, I told you that I was not aware of.
I am also not heard.
Aware.
Okay. So
it may be correct because so many things are there in the literature
which we do not know.
Science which that's why I admitted that I don't know. I don't know.
Ibrahim is still there. Ibrahim?
Yes, sir.
Have you assessed his migraine? And do you think prophylactic treatment is necessary for him? And how do you say that a patient should have prophylactic treatment in migraine?
Sir, a patient with migraine should have prophylactic treatment if the migraine attacks are severe enough to cause disability.
No. There are certain criteria. I think James will know. Before that, did you make an attempt to do this?
No, sir.
It should be done because she has migraine and you have sent her without any medicine. So supposing she gets a migraine, so we should assess her and think whether she should have a prophylactic treatment. Now, James will tell us how to know whether a patient, what are the criteria. James?
Sir, migraine, if a person is getting headache 4 times per month, at
so
least
that's a criteria.
Four times per month, at least for 3 months, then she should or he should receive prophylactic treatment.
So that's a criteria. Very good. Okay.
One thing you have to remember, in our general practice side, you have to remember that you have to assess how much disabling is the headache, even if it is less than. Sometimes a single headache per month may be so disabling to the patient. Even if it is one, if it is very disabling, in the general practice side, we may have to give treatment. But the international criteria is this one.
Okay, thank you. Ibrahim learned, we also learned. Okay, thank you,
Just
James.
one question, Matthew Thomas, one question to Ibrahim.
Yes,
Professor James was telling about low or CSF volume headache. Can you get the clinical clue? CSF headache, low volume. CSF low volume headache. He was referring to that. You remember? That is not CSF hypertension, CSF hypotension. What is the clinical clue? History can make you suspect that. Any idea?
No, sir.
No.
I think with position it may change. Logic.
Orthostatic.
I do not know. I do not know, but by logic it can be the positions of the patient.
What I understood is orthostatic. When the patient sits up and stands up, headache increases, and when the patient lies down, it immediately disappears. Is it, Dr. James?
Correct, sir. And possibly it is very specific for low pressure.
Yes.
Low CSF pressure.
Correct.
I think if there are no more questions.
I'm very happy, sir. I am with you. Both of Matthew Thomas sir and Thomas sir, they are all my teachers. And I am very grateful to Harish for giving me a chance to sit with them. It's a credit.
And Dr. James is from my place, sir. Pampala, Punyar.
Okay.
Even though he's in Calicut, everyone is in Punyar, very close to my
He's our
teacher. My teacher, and I shall frankly tell you, I was so surprised to see the clinical diagnosis done by Sharma sir when he was taking routes. And I shall tell you, Ravindra sir and Sharma sir was actually my mentor during my MD and MBBS time. So I am very happy that, and Matthew Thomas sir, even though he has not taught me, he is also in my teacher's position. When I was doing DM in Trivandrum, sir was, I think, associate professor, and unit chief. And sir may not be remembering that I used to, the PGs at that time, they used to say about you in very high terms, and I have very much respect as my own teacher to you, sir.
I consider you as my own student.
Sir, one Dr. Gangadharan has given both presentations very excellent. Complicated case gone through relevant investigations leading to correct diagnosis and treatment. Both patients escaped. Congratulate the doctors, presented the case, and experts who guided the procedure. Okay, it's a compliment from the doctor. Yeah.
I think if there are no more questions, and I think we'll close this session. And thanks, Suma, for bringing both these cases and for the nice presentation by the PGs.
Yeah, done well.
Thank you,
Thank you, Suma.
Thank you, sir.
So James sir, ഒന്ന് പറയാനുണ്ടായിരുന്നല്ലോ sir.
I was going. Matthew Thomas sir already told that I was thanking the department of Alapi, medicine department, for bringing both cases. Very nice.
James sir, ആലപ്പുഴ മറക്കാൻ പറ്റില്ലല്ലോ.
ഇല്ല ആലപ്പുഴ മറക്കാൻ പറ്റുമോ? ഞാൻ പ്രൊഫസറായിട്ട് 4 കൊല്ലം ഉണ്ടായിരുന്നല്ലേ.
അതെ അതെ അതെ.
സാറ് കാലിക്കറ്റിലെ ഞാനിവിടെ വോളണ്ടറി ട്രെയിൻ ചെയ്തപ്പോഴാ സാർ അവിടെ എത്തുന്നത്. ഞാനൊരു ന്യൂറോളജി
കാലിക്കറ്റിനെ പിടിച്ചു നിർത്തിയത് ഹരിയാണ്. ഹരിയാണ് എനിക്ക് വീട് സംഘടിപ്പിച്ചു തന്നത് ഇവിടെ.
Thank you, sir.
Okay.
Thank you.
Thank you.
Sir, on behalf of APA Kerala chapter, I thank all the teachers, Sharma sir, Matthew Thomas sir, and Dr. James sir, and Dr. Sanjeev Nair, and both the postgraduates, Dr. Ibrahim and Parvati, who has done well. And lastly, I have to thank the sponsors who is regularly doing making the platform for us, Cases Pharma, Mr. Unni, Vineet, and the main Ashokumar MD, who is doing every time helping us in doing this progress in a virtual platform. And these platforms, these presentations are available in YouTube also. Again, you can view who are missed because of their many people who will be having a duty and other things. So all these presentations will be available in YouTube. So you can view it later and you can share to your friends also. Okay, thank you.
Thank you everyone.
ഹരീഷ്, ഇത് എങ്ങനെയാ യൂട്യൂബിലെ ഏത് ഇതിലാ സെർച്ച് ചെയ്യുന്നത്?
സാർ ഇതേ തന്നെ സാർ, ഇതിൽ തന്നെ സെയിം സാർ. നാളെ ഞാൻ ഇതിന്റെ ശരിക്കുള്ള റെക്കോർഡിംഗ് അവർ ആക്കി തരാം, അല്ലെങ്കിൽ ഈ യൂട്യൂബിൽ തന്നെ നമുക്ക് വ്യൂ ചെയ്യാം സാർ. നാളെ
നമ്മുടെ പേജസിന് കൊടുക്കാം
സാറേ. സാർ അത് അയച്ചു തരാം. കഴിഞ്ഞ പ്രാവശ്യം ഞാൻ അയച്ചിട്ടുണ്ടായിരുന്നു, കഴിഞ്ഞ പ്രാവശ്യത്തേത്. ഓക്കെ.
ആക്ച്വലി ഇൻവിറ്റേഷനിലെ യൂട്യൂബ് ലിങ്കിൽ ക്ലിക്ക് ചെയ്താൽ തന്നെ കാണാം. ഇൻവിറ്റേഷനിലെ യൂട്യൂബ് ലിങ്ക് ഉണ്ടല്ലോ.
സാർ ഇൻവിറ്റേഷനിലെ യൂട്യൂബിൽ തന്നെ കാണാം സാറേ. ഓക്കെ.
നമ്പർ 2 സൂം റെക്കോർഡിംഗ് നമുക്ക് നാളത്തേക്ക് അവൈലബിൾ ആവും.
അതും തരാം സാറേ. ഓക്കെ.
Thank you. Good night. Good night. Thanks.
Thank you, madam.
Sir.
Thank you, Dr. James.